Good evening, everyone. I'm Tony Segreto, and once again, truly honored to be your moderator for tonight's In the Know Town Hall. We welcome all of you, and happy St. Patrick's Day as well. Tonight we're going to focus on a critically important topic, women's health. An extremely fitting topic, wouldn't you say, during Women's History Month as we celebrate the contributions and advances made by women? It appears while we've made great strides in increasing the lifespan of women, we still have a lot of work to do to ensure that we meet the unique and long-term health needs of women. Now, while women and men suffer from a wide range of similar diseases, it's the symptoms, the impact, and the consequences that are often different for women. And the numbers bear that out. For example, let's talk about heart disease. It is the leading cause of death for women nationwide, accounting for about 1 in every 5 deaths. Did you know that's a higher mortality rate than for men? Women's reproductive health, from pregnancy complications to sexually transmitted diseases, all pose major risks. Mental health is at stake as well, with women twice as likely as men to be diagnosed with depression. So tonight, what we have done is put together an incredible, and I underline incredible, an incredible panel to discuss what UHealth and the Miller School is doing to address the unique health burdens that women face every single day. We're led by Dr. Michael J. Pados, the chair of the Department of Obstetrics, Gynecology, and Reproductive Sciences, and the professor of the Clinical Medicine Center at the Miller School of Medicine. He'll be joined by Dr. Marie Delgado, an assistant professor of medicine in the cardiovascular division at the Miller School. And also joining the panel tonight is Dr. Karen Koffler, the medical director of the Osher Center for Integrative Medicine, and Dr. Nicole Mavridis, Associate Professor of Psychiatry and Behavioral Sciences. She is also the Medical Director of the Child Psychiatry Consultation Service and Program Director of the Child Psychiatry Fellowship Program at the Miller School. Needless to say, as you can see, it is truly a world-class group of experts. How fortunate are we? Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Pados has delivered his opening remarks, all panelists will answer the questions that you've submitted over the last few days. And they're great questions, by the way. But you're also going to have the opportunity to submit questions during this program. For those of you who have been with us, you know the drill. For those of you who are new, at the bottom of your screen, you're going to see a Q&A feature. That's the feature you use to send us your questions. And a reminder that every question submitted will be anonymous, and we promise we are going to get to as many as we possibly can. But in order to do that, we have to start this program. So it is now my pleasure to introduce Dr. Michael J. Pados. And Dr. Pados, thank you so much. We know how busy you are for joining us this evening. Happy St. Patrick's Day.
Good evening, and thank you, Tony. I'm delighted to join you tonight. And I'm equally honored to speak on behalf of our extraordinary faculty, staff, and physicians of the Departments of Obstetrics, Gynecology, and Reproductive Sciences here at the Miller School, as well as my colleagues joining me tonight on this panel. And happy St. Patty's Day. This is such an important topic. Women face health burdens that often have lasting familial, social, and economic implications. This is particularly true for women of color who experience disproportionately worse health outcomes, often because of the lack of timely interventions. For instance, take heart disease. As you mentioned, Tony, heart disease is the #1 killer of women nationwide. Yet for so long, cardiac diseases were considered to be men's disease. Since women do not exhibit the classic heart disease symptoms, that they often don't access the early care they need to survive. Thankfully, this is changing through increased awareness, but there is still much more work to be done. Not only do diseases present differently in women, but by virtue of biology alone, women experience a slew of health conditions that require specialized approaches, from hypertension and hormonal imbalances to gastrointestinal disorders and uterine diseases. We here at UHealth and the Miller School of Medicine are addressing the unique prevention and treatment needs of women. Dr. Delgado will help us understand cardiovascular disease and the latest information on how women can better protect themselves from this deadly disease. It is true that women are twice as likely to experience depression than men. By virtue of their role in society, between work and family responsibilities, women can experience incredible anxiety and stress. Dr. Mavridis will walk us through ways in which women can protect and treat women's mental well-being. Dr. Koffler can help us approach women's health through the lens of prevention and shed light on the integrative health approaches that address ailments from gastrointestinal disorders to brain health. I hope to share the latest treatments and innovative research on women's reproductive and gynecologic conditions, such as the use of genetic and biomarkers to predict diseases affecting women, and the link between reproductive and cardiovascular health. Tonight, we will highlight the connections between many of the women's health issues in our fields of expertise, building on each other's knowledge to help us dig deeper into this important topic. We look forward to answering all of your questions. Tony?
Dr. Pedas, thank you. Thank you for setting the stage. And now let's turn our attention to the questions that you've submitted. And Dr. Delgado, we're going to kick it off with you. Welcome. What is the easiest way for a woman to know her risk for heart attack and stroke?
Well, good evening, everybody. Hi, Tony. So this is a very exciting moment to talk about women's health. So the number, let's try to think about heart disease and stroke is going to be the majority of death, cause of death for all of us. So we need to know what is the main or what's the most important risk that can lead to that. So for women, as usually they are the head of the family as well, they need to understand what is their blood pressure. People and women in general tend to think blood pressure is just a number sitting in the corner and your heart disease is something different. What you have here, and this is a familiar risk, is what's going to eventually put you at risk of heart disease or stroke. So the most easiest way to understand if you are at risk is go back. Ask your family, ask your parents, ask your grandparents, have you ever had hypertension? Did you take pills for blood pressure? Have you ever had a heart attack? So the number one is to understand your past and then look at yourself. And the one simple thing everybody can do at their home, especially women, is just to measure their blood pressure and understand whether they have hypertension, which will be in women the number one risk factor for heart disease and stroke.
Thank you, Dr. Delgado. Dr. Koffler, welcome. It's nice to see you again.
Thank
Weight
you.
gain, hormones, and diet. What works?
Weight gain, hormones, and diet. Yeah. So if you're talking about when we start putting those three together, we're often thinking perimenopausal women. And so it's a real opportunity, when we lose our hormones as women, as we go through the transition, and that can span, a decade really. It's an opportunity for us to really take stock in our health habits, because it is true that it can often be much more difficult to lose weight postmenopausally, but it is not at all impossible. So what really works during these times is to take stock in what you're eating. By far and away, the most important thing for metabolism is what you eat, when you eat, how you eat. So I think sugar is way too prevalent in our diets. There's very few of us who can live without a daily dose of sugar, and we are eating far more today than at any other time, and we're not built for it. So that's one major thing. When we eat is incredibly important. If we're eating late, there's no real opportunity to use those calories, and it can disrupt our sleep, which will also contribute to a disordered metabolism. And then how we eat. Many of us are not even awake to the fact that we're eating, and we may consume way more than we need to. So there is no perfect diet out there. You know that because when you go to the bookstore and you see, or Amazon, and you see tons and tons of diet books, no one of them work, and any one of them might work. And the reality of it is we all have to find our own correct diet. And that's a combination of how we were raised culturally and what really works for our biochemistry. So there's, I'd love it if there was an easy answer. I'd love it even more if there was like an easy pill to take, especially if it was an herb. None of that exists. it's your daily habits, and it's, of course, your movement, your daily movement. So sleep, movement, food all figures squarely into how you'll feel even as you go through menopause and your hormones are no longer contributing to your metabolism.
Thank you, Dr. Koffler. It's truly an avalanche of diet information that we get every single solitary day.
True.
Dr. Mavridis, welcome. Nice to see you. This question's for you. I am worried that I have postpartum anxiety, depression. How can I tell, and what do I do?
Thanks, Tony. So this is a question I think we get asked all the time. It's one of the things that other departments are calling us and asking about this, especially our colleagues in OBGYN. And I think it's a really scary thing for women who are going through the pregnancy to wonder, is this going to happen to me? Am I going to get postpartum depression? It's very, very common. With depression, especially, we hear about the baby blues and that hormonal changes right after birth and delivery. But after that kind of stabilizes out, maybe 3 to 4 weeks kind of post-delivery, the people who are still having trouble sleeping, appetite changes, mood changes, it's hard to know whether that's from depression or is it from, being super sleep deprived because of a baby. But the things that we want people to look for are someone, if you're not feeling interested in your baby, if you're not bonding with them, you're crying for no reason, severe anger and crankiness, not just like I'm a little bit annoyed at my partner or my spouse, but like wanting to throw things or get super angry, or just everything is driving you crazy, feelings of worthlessness. And especially if there's any thoughts of hurting oneself, hurting one's loved ones, hurting one's baby, these are all really big warning signs that this is more than just the normal hormonal fluctuations from pregnancy and delivery. And they say that the most prevalent time is within the first couple of weeks or first couple of months after birth, but postpartum depression can really be experienced anytime within that first year after delivery. And I think that we get a lot of information about postpartum depression, and I don't think a lot of people even know that there's such a thing as postpartum anxiety. It's not something that I think people are really talking about as much, but it's really there. So this can be someone who has never had any anxiety ever before, like just, normal anxieties here and there. And then they give birth and the anxiety just skyrockets. And it's not just that normal, like, oh my gosh, I have a kid and now what do I do? It's, I'm super sleep deprived. I can't relax. I can't go to sleep. They're constantly on edge about worrying about, is something bad going to happen? Is something going to happen to me, to the baby, to my spouse, to my partner? What is going to happen? Some people will even have trouble sitting still, even when the baby is asleep. They just cannot relax. It can also take the form of postpartum obsessive compulsive disorder, where now someone is checking or having repetitive thoughts or hand washing or watching the baby over and over and over again. It can be very hard to recognize in oneself. And I think this is a kind of a key for partners, spouses, loved ones to really say, hey, there's something really different going on with with the mother of our baby. And like, we need to figure out what's going on. The first step is almost always talking to your OBGYN. If you're in already mental health, care under a psychiatrist, psychologist, social worker, anybody, reaching out to them. At the University of Miami, there's the perinatal clinic that we have through our Department of Psychiatry, where we're always taking new patients. It's run by Dr. Vanessa Padilla and myself, and we are always there to help, figure out whether or not someone needs a medication, someone needs just some counseling and therapy, and what level this is going on. If it's, of course, reaching that level of thoughts about hurting oneself or hurting a baby, you can always call 911. You can always go to your nearest emergency room, but we here are definitely here to help. And I think it's really scary for women to just not have anyone to talk to about it. It seems like it's a stigma, but it's really very prevalent, and not to be afraid about bringing it up and asking for help to any of your healthcare providers that you're seeing.
Dr. Mavridis, thank you. Very, very prevalent and very real, which is a scary thought for a lot. Dr. Pedas, we want to welcome you back. I have preeclampsia. What does this mean for my health, and is there anything I can do?
Tony, thank you. And what a great question that is. And it ties into what Dr. Delgado was just talking about, and also Dr. Mavridis, the stress. So for those of you that may not have heard, but preeclampsia is a unique disorder that happens in pregnancy. So it's unique to women. And one of the features is that we commonly see high blood pressure associated with it. And this can happen to various times during the pregnancy, usually in the later half of the pregnancy. And for women, it's a major cause of like significant disease during pregnancy, also in rare cases, maternal mortality, and also has implications for the baby as well, mostly due related to prematurity. And this problem is increasing in our population for many of the reasons that I think Dr. Koffler hit on it as well. For basically our population itself, the obesity rates are high, and so that's driving a lot of this as well. So we as a population generally are a little bit sicker, quote unquote, than we were, many decades ago. So, there are two key points about all of this. So one is, after this happens, most of the time the preeclampsia resolves, and that's very good, except that what we've known now, and we were part of the largest studies worldwide to look at all of this actually over the past 15 years, is that you could think of preeclampsia as a stress test of life. So you don't really have to get on a treadmill to get a stress test. You can look backwards, like Dr. Delgado said, and get your history. And what we know now is that preeclampsia is a marker for three things later in life, especially. One is chronic hypertension, the other is blood clotting, and the other is diabetes. So after pregnancy, if you've had preeclampsia, it's not just about going back to your obstetrician, gynecologist, and getting a pap smear and that being the end of it. We actually have to follow your blood pressure afterwards and also screen for diabetes. Now, this whole topic is emerging still. We're still working on ways that we can detect who's going to be at super high risk for complications. So one message is you need to be followed afterwards. Depending on the severity of it, usually a few weeks, sometimes in the severe cases, very soon, days after you leave the hospital, and then spread out like a few months, and then 6 months, and then a year. Now, for a future pregnancy, you're also at increased risk. And right now, low-dose aspirin is probably the best prevention strategy that we have that you can take. And it's been well studied and safe and cuts your risk in half. So these are really important things. And what we've also shown is that women that have had preeclampsia also are at higher risk for some discrete heart disease as well, like ischemic heart disease. So it's not just the chronic hypertension, but other things as well. Now, what we're also studying are other kinds of complications, sort of non-cardiovascular endpoints. And we've shown some very interesting work already that to keep us paying attention to this. So preeclampsia is a marker. That's what I want to get across to everyone. And thanks, Tony, again, for asking that great question.
Thank you, Dr. Pedas. Dr. Delgado, we just had this question sent in to us. You pointed out the risks associated with high blood pressure. What about low blood pressure? Are there any meds for that? What do we do for that?
So, low blood pressure. Let's start with the fact that half of the population in the United States have high blood pressure. So blood pressure is actually high. And everything, when we look at blood pressure, we look at basically mechanics. You have blood running in your vessels and you have a pump, okay? So you need this pump and these arteries to contract for the blood to go to your brain, to your different organs and be healthy. So what happened with hypertension is that, not only there's a problem pumping, but there's also a problem delivering oxygen the right way. With hypertension or low blood pressure, it's kind of tricky because we don't look at the number either. We don't look at low blood pressure. We look at what we call the mean arterial pressure, meaning there's a degree of blood pressure where you can still have a very good blood flow. So if you compare quote unquote low versus high, obviously the mortality and the cardiovascular risk goes with high. With low, the problem is when you're symptomatic. So your blood pressure is low, but you feel it. You feel that you're dizzy, you feel that you can't be yourself. And that happens, by the way. And it's sad, it's not sad, it's very interesting going through this very lovely conversation, not touch the point of COVID. So what happened with COVID, specifically with women, is that not all of them, of course, we're talking about probably less than 5% of the women that had COVID or had the COVID vaccine. We read that we will develop something called, it's like a post-COVID syndrome, and they will have this craziness in blood pressure variability and heart rate variability, meaning that the blood pressure goes up and down. And the patient or herself, they feel it. They feel that the blood pressure is low. So with low blood pressure, well, besides trying to understand why it's low, the big problem is that when your blood pressure is too low, and we're talking about mechanics, so the blood flow to your brain, for example, can be momentarily impaired, and you will be like, oh, I'm going to be dizzy, or you're going to fall. But in terms strictly of risk for cardiac disease, of developing arteriosclerosis and MI or a stroke, it's very unlikely if your blood pressure is, for example, 100/60, even though it's very normal for some patients, they can feel that it's very low. Treatment and pills, and then going back to what we call integral medicine. Blood pressure is part of a combination of flow and contraction. So when a patient has low blood pressure, especially a woman that's symptomatic, she feels like, oh my God, my blood pressure is low, I feel dizzy. The biggest trick that I always tell my patients in the hypertension clinic, hey, just put a little bit of salt under your tongue. So basically, the circulation under your tongue is the closest to systemic circulation. And it's very interesting because whatever you put under your tongue goes to your blood pretty quickly. So salt starts a very interesting mechanism over your vessels and over your kidney. And once you put a little bit of salt under your tongue, you're doing what basically many drugs can do in reverting that, in increasing momentarily your blood pressure. Take a broth, drink, you can do that. But when you drink water with salt, what's happening? Your water goes through your stomach, and then it takes some time for transit and actually reflect in the way your kidney is going to behave. We absorb water because of the salt, and then increase your blood pressure. So if there's any trick without going into pharmacology, a little bit of salt will do the trick in any woman that feels that the blood pressure is low. But in terms of dying from heart disease, you will die, God forbid, from heart disease, most likely if you are hypertensive and if you don't take control of your blood pressure.
Fascinating, Dr. Delgado. Salt. Who would have ever thought? Dr. Koffler, we have another magic pill question for you. What are some natural ways to address sleep?
Yes, sleep, which can be so elusive for some of us. So, so when we are working with patients, we want to know if it's difficulty falling asleep or staying asleep. And let me just say, for anybody who owns a cat or a dog, they have zero issues falling asleep. They're super good sleepers, and so are all animals under the sun, with the exception of humans. And assuming it isn't due to something like pain, but really more a lifestyle thing, most often we find that people do not sleep well because they have remarkably busy minds. And for instance, I saw a patient recently who goes from her work station, which is in her bedroom, straight to bed. So of course, she's got the mindset of someone who's working, and she's got her brain heavily engaged, and then she just goes to bed. But if we remember what we do for children, there's a ritual to getting a baby to sleep at night. We start speaking more softly. They take a warm bath. we turn the lights down, we put a little soft music. Well, somewhere that disappears as we get older, but it's a great idea to bring it back. So first of all, part of the problem is we're not living with our natural circadian rhythms. We were designed to go to bed when the sun went down and get up when the sun came up. So we're constantly fighting a natural tendency to go to bed as it darkens. Every clock, we have clock genes within our cells that dictate that rhythm, but we turn on lights and we look at screens and we destroy that natural rhythm. So my bias is, number one, instead of trying to take a pill, first dim the lights, start easing yourself into a calmer state. If you're a TV watcher, that is not the time to be watching action movies or killings or, you know, things that put you on edge. Actually, if you're going to watch TV, and I would argue against that just strictly from the light emitted from either the TV or your iPad or your phone, that also reduces melatonin release, which we need in order to fall asleep and stay asleep. But if you are going to watch, the only thing I allow my patients to watch is comedy, because it actually induces a better physiology for falling asleep. So if you're not going to watch TV, I'd rather have you turning down the lights, taking a warm Epsom salt type bath, maybe a little lavender oil, reading before you go to sleep, and then naturally succumbing when your rhythms tell you to. And for many people, that's actually 7 or 8 p.m. and they push past that and they get a second wind and they're wondering why they're still awake at midnight. The reality of it is they should have gone to bed at 8. But of course, in our drive to be productive, most of us won't do that. Now, there are some natural things that you can do. For many people, melatonin actually works well, and you can boost your own natural melatonin production with 20 minutes of morning sunlight. So if you're a coffee drinker or a tea drinker, and by the way, if you have trouble falling asleep, you should be sure not to be getting in caffeine after 12 noon, or maybe earlier, depending on how quickly you metabolize the caffeine. So organizing yourself so that you have a calmer routine and taking melatonin. Now you need to take it several hours before you go to sleep. If you have trouble falling asleep, get regular acting melatonin. Start at a low dose, maybe 1 milligram, and you can go up from there. If you have trouble staying asleep, you want to try longer acting melatonin, with the understanding that if you are a wild dreamer, that melatonin can produce more vivid dreaming. And for some people, that's great fun. And for some people, it's more nightmarish. And then there are many other wonderful natural remedies that can help you to relax, including things like CBD, holy basil, L-theanine, which is rich in chamomile tea, which is why many cultures drink chamomile tea before they go to bed. I like people to do an exercise called progressive muscle relaxation. You can YouTube it to learn it, but you basically sequentially relax your muscles, starting at your feet and moving up, and or meditation. Meditation calms the brain so that you can succumb to sleep. So if you're active, and then you expect yourself to go to sleep, it's sort of unreasonable. But if you ease yourself through some of these practices, you're going to find it easier. One last thing I'd like to mention, because I see it all the time. A lot of people rely on a glass of wine to help them fall asleep. Now, wine, when you first drink it, is in fact a depressant, and it can help you fall asleep. Around 2, 3 o'clock in the morning, you're going to find it's more of a stimulant and you'll be waking up. So if wine is part of your routine, I would say hold that and just see if that improves your sleep. Use some of these other techniques to fall asleep, and see if not drinking wine helps you stay asleep.
Thank you, Dr. Koffler. I'm still a warm milk and honey guy.
And that works too.
Yeah, I've heard that and a little Seinfeld seems to always work. Dr. Mavridis, this question's for you. How can I manage my anxiety that's worsened since the pandemic?
Great question. And actually, Dr. Koffler actually mentioned a whole bunch of things that I was going to kind of mention as well, and I'm going to kind of spearhead off of her. Anxiety, especially for women, increased greatly over the pandemic. I think a lot of the uncertainty about, not knowing what was going to happen, combined with the fact of having to work and manage children at home, especially when the schools were all virtual, trying to run a childcare, run your child's school and work full time. Anxiety has been just skyrocketed. And even now that things are slowly starting to get back to normal, we're still seeing very high levels of anxiety, especially in our female patients. And I think some of the things that we talk about is like, what can you control, right? So obviously you can't control whether there's a new strain of coronavirus. You can't control whether your kid's school is going to get shut down, your kid's going to get sent home from school, but you can control your own routine. So, kind of getting yourself on a schedule, like getting up around the same time, showering, getting dressed, kind of having a good maybe 15 to 30 minutes to yourself in the morning can really help start your day, without all the craziness of, your home, your family, and even your pets. So kind of sticking to that routine can be really, really helpful, and kind of just spending that time literally doing nothing. It can be scrolling through your phone on Instagram. It could be, praying. It could be writing in your journal. It could be, just listening to music. It doesn't matter what it is, but it's taking time for yourself. I think self-care for women in general is not very good. We tend to want to care for everyone around us first. And there's that whole, theory when you're on an airplane and your mask falls down, you got to take care of yourself before you take care of everyone else. And I tell this to all of my families, whether it's when I'm working with a parent who, I'm feeling treating their kid, you can't take care of anyone else if you're not taking care of yourself. So you got to find something that's pleasant, that's relaxing, that's enjoyable, whether it's reading a book, exercise, watching a movie, putting on something silly on Netflix, watching a silly reality show, sports, whatever it is, doing that in your evening hours when you really have some downtime, even if it's only a half an hour to an hour time, just doing something for yourself every single day. The other thing is limiting your media use. Don't be on social media. Don't be on the news all the time. I know that at the height of Corona, everyone was getting alerts 24/7. I'm like trying to see what was the CDC going to say now. Turn it off. I tell people, check your phone, check your news source 2 times a day. 3 if you really have to. Morning, lunchtime, after dinner. Not close to bedtime, because you don't want to have your screen time affect your sleep, as Dr. Koffler just mentioned before. But all these things can be really, really helpful. People get so much anxiety by reading, all the thing that's going on around them. And if you're reading it 24/7, every time CNN or Fox or MSNBC puts out a news source, you're going to be like overwhelmed completely. So limiting how much you're doing, limiting the news sources that you're having, and taking time for yourself and finding good self-care can be really, really helpful for anxiety. If that doesn't work, then reaching out to your primary care doctor to get referred over to a psychiatrist, psychologist, some sort of licensed mental health counselor, as there's so many more options now than there ever were before because of the telehealth platform. So there's lots of options for help.
Doctor, that's such great information. It really is. And it basically comes down to pampering yourself a little bit,
A little bit. Yeah, absolutely.
Giving yourself that time. Thank you. Dr. Pedas, I recently had a miscarriage. Why did this happen? And what does this mean for me? What do I need to do if I have another miscarriage?
Thank you, Tony. Really a great question to a really vexing problem for us. And it's very emotional for everyone, especially, the woman that's going through this, but not only her, but everyone around her that's touched her, and dare say, even the physicians and care providers involved with all this. It's a very traumatic experience. So, the way that I would think of it is like this. Generally speaking, the very early miscarriages that are occurring is sort of nature's way of kind of taking care of things that really didn't go right from the very beginning that were abnormal, genetically abnormal. And the message behind that is that there also could be some comfort in knowing that it maybe is a kind of one-time issue, even though it's extremely traumatic. And I would say in general, as I've been dealing with patients over these many years, I really try very hard to try to find the reason, especially if the patient wants to. So the way to think about this, and I find that most patients really like to have information. Why did it happen, etc. So typically, what's most important is, if it's possible, when someone is going through a traumatic experience like that, to be able to evaluate the products of conception, have that genetic evaluation. That's kind of like the first most important thing to do when you're in the situation where you can actually have that done. And for early pregnancies, that really is probably the lion's share of what's happening. But we're really at the dawn of a new era of trying to understand early pregnancy events. And so what we know now is it's not only genetics, but here we're really focused on trying to understand the implantation events, the actual attachments, what's going on, what is that early sort of placenta, fetus, embryo unit doing, and interacting with the mom and the uterine lining. And so there are areas of interest that we're focusing on here to try to uncover, new therapies and prevention strategies. So, and that's spinning off into new therapeutics. But in answer to your question exactly, one is we want to take care of the emotional and mental health component about all of this. One. Two, we want to empower our patients. So then we can go through kind of a sort of a list of things that we like to do. I mentioned that one of the most important is to have that genetic evaluation if it's possible. Then we kind of look at other causes of pregnancy loss potentially. There are some unique immune and blood clotting related disorders that sometimes first present with pregnancy complications. So we want to be in tune to that. And we look very carefully at the uterine lining as well. And we also look at the genetics of the couple, because sometimes, you are normal, but you can have a genetic rearrangement. And in some cases that can be passed off to the offspring. And that can be very important to know about, for both to answer that particular pregnancy loss and also what that means for reproductive options in the future. When a patient has more than one loss, we really make sure that we try to do this complete evaluation. And I would say the one thing to mention is that the vast majority of time, patients will go on to have successful, full-term, healthy babies, even when you've had 2 or 3 losses. So that's the good message behind it, that far and away, there usually are ways to actually have a successful pregnancy. Now we're looking at the things, as you've just heard about all of this COVID-related, talk, that's certainly been a hot topic. And we're doing a lot of research in the COVID area. Now, fortunately, COVID really doesn't pass through the placenta, the virus, a lot. But it does happen on occasion. And most of the pregnancy complications related to COVID have to do with preterm birth, preeclampsia, and sometimes distressingly, losing the pregnancy. But it's not that common about it. So our message is, there's definitely hope. Far and away, you will have successful outcomes after. And even in women that have serious medical conditions, usually there are some treatments that we can provide that can, navigate successfully to have a great outcome.
Dr. Perez, thank you. Such great information. Dr. Delgado, you seem to have hit a nerve with hypertension, because the question goes, how does hypertension affect the heart differently from men?
Okay, so let's start with women, right? As Dr. Paida say, women's are different from the moment they're birth, pre-puberty, puberty, then the time of their life when you're going to be pregnant, and then after pregnancy comes over the years, you know, the decrease in hormones, and then you are premenopause and menopause. So structurally, biochemically, even the body itself is different between men and women, okay? So I'm going to talk first about just plain physiology. The two bodies are different. So a 30-year-old female and a 30-year-old male have different body structures in terms of height and the size of the organs. So we're going to go back again to mechanics. We have blood that flows through the vessels, and we have a little heart here. So understanding how blood pressure affects the heart, just imagine you have a pump that is going to pump against resistance, and the resistance is given by your arteries, okay? So my heart, this heart is pumping, and it's going to pump harder when the resistance is greater. And in women, that heart is different structurally and in size than in men. And that heart pumps, gets resistance. And what happened with a woman, it had been shown that happens earlier and more frequently. The structure of the heart gets bigger, and that's what we call hypertrophy. So women have more hypertrophy or growth of the muscles of the heart compared to men when you compare them in periods of life. So what is this big deal? Well, it's your heart, right? And common sense says something happens to your heart, you're most likely going to be in big trouble. And you can die if your heart stops, right? We need blood that circulates around all the time. So when our heart works harder and we start developing hypertrophy, we're literally changing the structure of the heart. And we're also changing the way the heart works and the physiology of the heart. So we have one, a structure of the mass. So what does hypertrophy, what's the importance of that? Well, hypertrophy in the heart gives you a higher risk of heart attacks, give you also a higher risk of arrhythmias, okay? And that is just a physiological consequence of increasing your pressure. The other thing is physiological as well. So if my heart gets bigger, my heart also doesn't contract as it should during that resistance. So I'm contracting, the blood flows, but there is a problem when the blood tries to go forward. And that's the initial phases of what we call heart failure. Most of us, right, in the community knows what heart failure is. Heart failure, you get short of breath, you get water in your lungs, and you tend to think it's the old person down the road who gets heart failure. No, you can start pretty early on with what we call diastolic dysfunction and diastolic heart failure. And it's typical and it's more common in women. And again, it's consequence of sustained blood pressure or hypertension damage into the heart. So what happened is, it's typical a woman later in her 60s, more or less after 50 years old, hypertensive for many years, probably not well controlled, and suddenly comes to the hospital with shortness of breath, and they do an echocardiogram, and they, even though quote unquote, you're probably familiar, the ejection fraction is normal, they still have heart failure. And again, these are like extremely very important red flags that something's going to happen later on in the future. So this is one of the important, just from the mechanistic standpoint. And again, it's a structural. My blood circulating in my body, right? If I have a resistance here and I'm pumping, this pump is going to be affected. And that's the hallmark of how blood pressure affects the heart, just from the mechanical standpoint. We're not talking about biochemical markers or hormones that get activated or biochemical activation of receptors that will lead to abnormal response. This is just plain mechanics. And the other easy way to see it, that I always give that example, God forbid you get, somebody gets shot and they lose a lot of blood, right? It's the opposite. You don't have blood to pump, and you don't have pressure. So that's why the streams are so bad. So hypotension to the stream of causing death is because there's blood loss, or there's so much vasodilatation that there's no way that the heart can pump in an efficient way to deliver blood. So the heart is struggling. That's something that I think women needs to understand very early on with hypertension. I think that the major misconception that we have about hypertension is that it's just a number. And if that number is on target, you're off the hook. So hypertension, and this is, I know Dr. Prada will agree with me, even when the baby is in the womb, okay, when the baby's in the womb and the mom is hypertensive, the mom vascular environment affect the protein expression in this fetus. And this is independently of the genetic risk that is being transmitted. So hypertension, when you start seeing your kids growing up and then becoming adults, hypertension starts basically as a endothelium, or what we call vascular dysfunction. So the vessels don't respond normally. And what I try to explain all the time, that is longitudinal. So increases over time. And whether we want to see it, whether we want to label it as hypertension, and sadly, as many young women get labeled, you're not hypertensive, you're actually nervous. No, that's not hypertension. You have anxiety. You better go to the gym and lose weight or do something. And they literally spare basically 10, 15 years in the life of the patient when this woman doesn't get treatment, because they're putting on the side. And sadly, I know this was not the question, but I'm very vocal when I try to explain the disadvantage that women have, especially from the cardiovascular standpoint. And I always give the example, if you're 30 and you're a male and you come to clinic with hypertension, you get everything. You get treatment, you get workup for trying to establish whether you had a risk of heart attack or not. And the woman, on the other hand, is being told at 30, you know what? You must be nervous. Don't worry about it. Continue checking your blood pressure. That this is you. There's no going back to the history. So basically, is longitudinal, affects the vessels over time, no matter what you do. And your heart will be the number one organ to be affected by hypertension. And in women, because of the body structure compared to men, will get more and devastating damage of the muscle of the heart than the function. So we have muscle function that will lead to what? Will lead to heart attacks, will lead to arrhythmia, will lead to heart failure. And eventually it's why it's the number one cause of death in women, heart disease.
Thank you, Dr. Delgado. Just amazing information tonight. Dr. Koffler, we just had this sent into us. Is there any treatment for severe fatigue and headaches when the air pressure changes because of rain or the threat of rain? You could probably even apply hurricanes to that.
It's a good question. I can't say I specifically know the answer. I'd open it up to our other panelists, but I do know that people have identified particularly headaches associated with changes in barometric pressure. So for instance, the weather we've had here in the last couple of days, today and yesterday, I know that often patients will describe that they have an increased tendency to have headaches, and maybe with that concomitant fatigue. But I don't know actually what the mechanism of that. I can just tell you I've heard it described. I don't know if any of the other panelists have heard that described.
Dr. Pedas or Delgado or Mavridis, any thoughts on that?
Well, I would just say, Karen, it's a great point. When in talking to my ENT colleagues, it seems like the vestibular changes in the inner ear are a lot more common, problems with that than we know of. So sometimes it's a different kind of problem that we haven't really thought about, and it's like an inner ear kind of issue as well. But I know it really is a complex, disease process. And I think, the changes that you just heard about with blood pressure, some people I think they're much more sensitive to these changes, right? And whether on a certain day you don't take in as much, you don't fill your tank as much, so you're a little bit dehydrated, and you have these other environmental stressors, and then all of a sudden, and then you add the hormones to it, and bam, it's kind of a perfect storm, so to speak.
Thank you, Doctor. Dr. Mavridis, I think I want to get pregnant, or I am pregnant. Do I have to stop my psychiatric meds?
So the easy, quick answer is no, please do not stop anything without talking to your doctor. But I think so many people think that, oh my gosh, if I'm on a anxiety medicine or a depression medication or a mood stabilizer, I can't be on them when I'm pregnant because it can't be good for the baby. But you wouldn't stop your asthma medication or your diabetes medication or your hypertension medication. So you should not stop your psychiatric medications the same way. Mental health is the same sort of thing as your physical medical problem. So you don't want to just cold turkey stop medications ever, because that can run the risk of definitely having worse symptoms and feeling terrible when you're just starting to be pregnant. The other thing is that what we say is, healthy mom, happy mom usually brings out a healthy, happy baby. And so what we like to recommend is if the mom can be stable when they're on their medications and they don't have fluctuation in mood or anxiety or anything like that throughout the course of their pregnancy, chances are they're going to be doing better than they would if they were to come off their medications, have an exacerbation of anxiety or depression, then have to go back on medications later in pregnancy. And then, so now you're exposing the fetus to not only a medication, but to all the different fluctuations, the neurochemicals that go on in the body when you're experiencing anxiety, depression, mood instability. So instead of having to experience all these different things and still maybe needing a medication at the end, we try and work with patients and get them on the lowest possible medication dose that they can be on, that they can be stable on if they're planning a pregnancy. And if you become pregnant and you weren't planning it, we work with patients on kind of, again, managing the lowest possible dose. But usually if a pregnancy that wasn't planned, you've already, exposed the fetus to a couple of weeks at least worth of medication. I'd much rather have the fetus be exposed to a low dose of some sort of medication than, all the other things that are unknown about experiencing anxiety, depression, and mood instability. So, the easy answer is please don't stop your medications without talking to your doctor. The more difficult question is that we will work with you to help you figure out the right dose, the right medication to be on, regardless of whether it's a planned or an unplanned pregnancy.
Thank you, Doctor. Dr. Pedas, what happens if we have another wave of COVID and I'm pregnant?
Oh, well, let's hope that doesn't happen, Tony, but we're going to be ready for this. We've been through 6 waves now. So, we've learned a lot, and really it's a credit here to all of our colleagues here at UHealth and the Miller School, not only taking care of patients on the front line, and I speak on behalf of our department and everyone that is on this panel also has been, on the front lines as well. And we've learned a lot about this. So now it's a little bit more familiar to us. So my message is the following. Right now, if you're able to be vaccinated and haven't been vaccinated, you should do that and get boosted. And because that's a single most important thing that you have to protect yourself, because the vaccines are safe and they will help to prevent serious morbidity and even those rare cases of mortality. So that's one. And then secondly, we just want to be in tune to what's going on. So all the prudent things that we would do now, in terms of masking and just being careful, decreasing exposure, really important. But if you do get pregnant and you haven't been vaccinated, get vaccinated at any point of the pregnancy. If you go through a pregnancy, get vaccinated in the breastfeeding period as well, the postpartum period. So we've learned a lot more now than what we've had. And we're still learning more about COVID. And in our own arena, we've actually developed an animal model to study COVID and now long COVID. And also we've invented a therapeutic actually that we're targeting for pregnancy and the early adolescent, early newborn period as well. So much is going on, and let's just hope that we don't have to actually go down to this path very far, and that it's kind of in the past. But I think, history tells us that we have to be ready for all this. But you know what? You can be much more ready for this now, and in the labor process, I will tell you that we've done a 360 on all of this as well. So in the beginning, when it was very new to all of us, and like our colleagues in New York, there was a brief period where we had to really limit people the supporter of the patient in labor. Now that's really not the case so much, so that we have partners and we allow doulas involved as well. So we are really come full circle. The breastfeeding piece, very important, that we want to encourage that, and where it's possible for patients, and the vast majority of patients can breastfeed for in very few cases can they not, for various medical or other reasons. So we'll help to guide you through all of this as best that we can. And by and large, with some slight increases in some of these pregnancy complications, we'll get you through it just fine. So that's my message. So don't delay childbearing. Don't delay trying to get pregnant for anything right now.
Dr. Pedas, thank you. And I don't know where this hour went, but that'll be our last question of the evening. And before we end the evening, Dr. Pedas, we'd love to hear some final comments from you.
Well, thank you, Tony. And thank you to all our viewers. Your attendance and your questions are really important to us. The importance of women's health and knowing ways to improve a woman's well-being cannot be understated. And I hope we've highlighted that tonight. At UHealth, we know this. And we do all we can to provide excellent care and advance the kind of research that responds to the needs of the women that we serve. What you've heard tonight reflects the innovation, passion, and commitment that is at the very core of our mission. Your generosity ensures that we continue to push on breakthrough research, deliver the best treatment options, and support outstanding physician scientists in the field of women's health. Of course, our physicians and scientists could not do this without you. You actually inspire us to go above and beyond to find solutions that will make a difference in our patients' lives. Thank you for joining us tonight, and thank you for everything that you do for us at UHealth and the Miller School.
Thank you, Dr. Pedas, and our panelists, Dr. Koffler, Dr. Mavrides, and Dr. Delgado. All of you tonight were absolutely outstanding, magnificent. We told you all the hour would fly by. It did. It really did. And we want to thank all of you for participating in tonight's In the Know Town Hall. This really has been a remarkable evening and such an important one. Women's health should be top of mind for all of us, not just the women. We all need to be observant. And if we sense an issue with our spouse or partner or loved ones, we need to address it, ask questions, and be caring and concerned, because we learned tonight again and again and again, early detection is critically important for a favorable outcome. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. Now, in a moment, you'll also see a survey about tonight's town hall on your screen. Please take a minute. It won't even take you that long. I've taken it. It takes about 35, 40 seconds to submit your feedback, because what that feedback does, it helps us understand your interest and improve our program. And as always, we wish you and your family good health. Happy St. Patrick's Day. And remember, it's all about the you. Good night, everyone.